In the heat of battle, when bullets are flying and shells are exploding around you, getting wounded is not a matter of if, but when. For World War II soldiers, medical help wasn't always just a radio call away. Picture this. You're pinned down in a foxhole somewhere in France, 1944. Machine gun fire is raking the ground above your head, and shrapnel from the last artillery barrage has torn through your leg. You're bleeding, you're in pain, and you're alone. The medic who was with your squad 20 minutes ago is now treating 3 other wounded men 50 yards away, but he might as well be on the moon. Enemy fire has you separated, and crawling to him would be suicide. This was the reality for millions of soldiers fighting across Europe and the Pacific. Sometimes the medic was pinned down by enemy fire. Sometimes he was treating someone else who was dying. Sometimes he was working on wounds so severe that he couldn't leave that soldier's side. And sometimes he was already dead, another casualty of the same battle that had wounded you. In those moments, when blood was flowing and pain was overwhelming, soldiers had to become their own medics. They had to know how to stop bleeding, treat shock, and stay alive long enough for real help to arrive. This wasn't a choice or a preference. It was survival at its most basic level. Combat medics were heroes, but they were also human beings with limitations. One medic typically served an entire infantry company, sometimes over 200 men spread across a battlefield that could span miles. When multiple soldiers were wounded simultaneously during an attack, that single medic had to make impossible decisions about who to treat first. The soldier with the sucking chest wound or the one with the severed artery. The conscious man screaming in pain or the unconscious one who might be bleeding internally. During the D-Day landings at Normandy, medics were often among the first casualties. They wore red crosses on their helmets and armbands, but enemy soldiers didn't always respect those markings. Some medics were deliberately targeted because treating their wounded kept other soldiers fighting. Others were killed by random artillery fire or stray bullets as they moved across open ground to reach the wounded. This reality meant that every soldier had to be prepared to save his own life. The Army understood this harsh truth, which is why basic first aid training was mandatory for every recruit, regardless of his assigned role. Cooks, clerks, and mechanics all learned the same life-saving techniques as frontline infantry because in combat, anyone could end up wounded and alone. The training was practical and brutal in its simplicity. Instructors didn't waste time on complex medical procedures that required years of education. Instead, they focused on techniques that could be learned quickly and performed under extreme stress by men who might be wounded themselves. How to stop bleeding with direct pressure. How to recognize and treat shock. How to use the few medical supplies each soldier carried. But training could only go so far. The real test came in combat, where fear, adrenaline, and pain could make even simple tasks feel impossible. Soldiers had to overcome not just their wounds, but also the psychological challenge of treating themselves while under fire. The human mind isn't designed to function clearly when the body is damaged and in danger, but World War II soldiers learned to push through that mental fog because their lives depended on it. This wasn't advanced surgery or sophisticated medicine. It was battlefield first aid at its most fundamental level. Soldiers carried small first aid kits, but more importantly, they carried knowledge that could mean the difference between bleeding out in a shell crater or making it to an aid station alive. The techniques they used were developed through centuries of warfare, refined by military doctors who understood that complex procedures were useless in combat. Everything had to be simple enough to perform with shaking hands, effective enough to buy precious time, and practical enough to work with minimal supplies. Some soldiers became remarkably skilled at these basic techniques through necessity and repetition. Veterans who survived multiple battles often became informal medics for their units, teaching newer soldiers practical tricks that weren't covered in basic training. How to use a boot lace as a tourniquet. How to pack a deep wound with cloth torn from an undershirt. How to keep a wounded man conscious and fighting shock until help arrived. The psychological aspect was just as important as the physical techniques. Wounded soldiers had to maintain enough mental clarity to assess their injuries, determine what treatment was needed, and execute that treatment while potentially still under enemy fire. This required a level of self-control and discipline that most civilians never have to develop. Fear was the enemy as much as any wound. A soldier who panicked when wounded was more likely to make mistakes that could cost him his life. Those who stayed calm and methodically worked through their training had the best chance of survival. This mental discipline became as much a part of a soldier's equipment as his rifle or helmet. In this video, we'll look at the simple but life-saving techniques that World War II soldiers used when they were alone, wounded, and fighting for their lives with nothing but what they could carry in a small canvas pouch, and what they remembered from training that might have happened months or years earlier. Every World War II soldier carried a small canvas pouch on his belt, usually positioned on his right side for easy access. Inside was his lifeline, the individual first aid packet. It wasn't much by today's standards, measuring roughly 4 inches by 3 inches and weighing less than half a pound, but it was designed for one critical purpose: keep you alive until real help could reach you. The standard Army first aid kit was the result of hard lessons learned in World War I, when soldiers died from wounds that should have been survivable. Military medical officers studied casualty reports and realized that many deaths occurred not from the initial wound, but from bleeding, shock, and infection that developed in the hours after injury. The solution was to give every soldier the tools and knowledge to buy time against these killers. The kit contained a few carefully chosen essentials: a field dressing with attached ties, a small tube of morphine called a syrette, and sometimes a packet of sulfa powder. Some soldiers also carried additional items like extra bandages or aspirin, but these 3 components formed the core of battlefield medicine. No fancy equipment, no electronic monitors, no complex instruments. Just the basics that had kept wounded soldiers alive since the American Civil War, refined through decades of military experience. The field dressing was the most important item in the kit. It consisted of a thick gauze pad roughly 4 inches square, with long cloth strips sewn to opposite sides. The gauze was designed to absorb blood, while the strips allowed the dressing to be tied securely around almost any part of the body. The fabric was treated to resist moisture and decay, important factors when supplies might sit in a soldier's kit for months before being needed. What made this dressing effective wasn't its sophistication, but its simplicity. A wounded soldier could apply it with one hand if necessary, and it worked on wounds of various sizes and locations. The key was understanding the principle behind it: direct, constant pressure on the wound until the bleeding slowed or stopped. Blood clotting is a natural process, but it needs time and the right conditions to work. The field dressing provided both. The morphine syrette was a marvel of simple engineering that looked like a small toothpaste tube with a needle attached. Inside was exactly 1/4 grain of morphine, enough to dull severe pain without causing dangerous respiratory depression in most soldiers. The design was foolproof. Twist the cap to break the seal, jam the needle into muscle tissue, and squeeze the tube to inject the contents. No measuring, no mixing, no complex calculations. Soldiers were taught to inject morphine into large muscle groups like the thigh or upper arm, never into veins or arteries. The drug would take effect within minutes, providing pain relief that could mean the difference between staying conscious and going into shock. But they were also taught to respect morphine's power. Too much could stop breathing entirely, and combining it with alcohol or other drugs could be fatal. Each syrette had a small metal tag attached by wire. After using the morphine, soldiers were trained to pin this tag to the wounded man's uniform, usually on the forehead or collar where it would be immediately visible. This told medics and doctors exactly when morphine had been administered and prevented dangerous overdoses. The tag also helped medical personnel track pain management and determine when additional doses might be safe. Sulfa powder represented the cutting edge of 1940s medicine, the closest thing to an antibiotic that field soldiers possessed. Sulfanilamide had been discovered in the 1930s and proved effective against certain types of bacterial infection. For soldiers, this meant sprinkling the white powder directly into wounds could help prevent the deadly infections that had killed so many wounded men in previous wars. The powder came in small glass vials or paper packets, each containing enough sulfa for treating 1 or 2 wounds. Soldiers were taught to clean wounds as much as possible before applying the powder, though in combat conditions, clean water wasn't always available. The sulfa would mix with blood and wound drainage, creating a barrier against bacterial growth that could keep infections at bay for the critical first hours after injury. However, the most important tool wasn't in the kit at all. It was what soldiers learned in basic training and refined through experience. How to think clearly when hurt and scared. Medical supplies were useless without the knowledge and composure to use them correctly. This mental training was often more valuable than any physical equipment. Soldiers learned to assess wounds systematically, starting with the most life-threatening injuries and working down to minor problems. They were taught to recognize signs of shock, understand the difference between arterial and venous bleeding, and know when a wound needed immediate attention versus when it could wait for professional medical care. The psychology of self-treatment was equally important. Natural human instincts often worked against effective first aid. The urge to look at a wound repeatedly, to remove blood-soaked bandages to check on healing, or to use all available morphine immediately for pain relief could actually worsen a soldier's condition. Training helped override these instincts with disciplined responses that improved survival chances. Soldiers also learned to adapt their limited supplies to different situations. The field dressing could be used as a tourniquet if folded and twisted properly. Morphine could be saved for the most critical moments rather than used immediately for any pain. Sulfa powder could be mixed with water to create a paste for certain types of wounds. This flexibility meant that even basic supplies could be remarkably effective when used intelligently. When a soldier got hit, the first few minutes were critical, not just medically, but psychologically. Panic could kill you faster than most wounds, causing soldiers to make fatal mistakes or waste precious supplies. So the first rule, drilled into every recruit during basic training, was simple but vital: stay calm and assess the damage. This assessment had to happen quickly but systematically. Soldiers were taught to check for bleeding first, since severe blood loss could cause unconsciousness or death within minutes. They looked for bright red blood spurting from wounds, which indicated arterial bleeding and required immediate attention. Dark red blood that flowed steadily suggested venous bleeding, serious, but usually manageable with proper pressure. The location of wounds mattered enormously. Head and chest wounds were typically beyond field treatment and required immediate evacuation. Abdominal wounds were dangerous, but could often be stabilized with proper bandaging. Arm and leg wounds, while painful and potentially serious, were usually within the scope of self-treatment if soldiers kept their heads and followed their training. For bleeding wounds, the primary technique was direct pressure, applied immediately and maintained consistently. This wasn't gentle pressure like treating a minor cut. Combat wounds required firm, continuous force that would compress damaged blood vessels and allow natural clotting to begin. Soldiers pressed the field dressing hard against the wound and held it there, sometimes for 10 or 15 minutes without relief. If blood soaked through the first dressing, the cardinal rule was never to remove it. Taking off a blood-soaked bandage could restart bleeding that had just begun to clot, potentially causing more blood loss than the original wound. Instead, soldiers were trained to add another dressing on top of the first one and continue applying pressure. Some wounds required 3 or 4 layers of bandaging before bleeding stopped completely. When direct pressure wasn't enough, soldiers were taught to find and use pressure points. These were specific locations where major arteries ran close to the bone, allowing external pressure to reduce blood flow to wounded areas. The most commonly used pressure points were in the groin for severe leg wounds and in the armpit for serious arm injuries. Applying firm pressure to these points could slow arterial bleeding enough to allow clotting while soldiers worked on direct wound treatment. Learning these pressure points required memorization and practice. In the groin, soldiers pressed hard just below the center of the pelvic bone, where the femoral artery supplied blood to the entire leg. In the armpit, pressure applied against the upper rib cage could slow flow through the brachial artery that fed the arm. The technique required significant force and had to be maintained while applying other treatments, making it challenging for wounded soldiers to perform on themselves. Tourniquets were a last resort, used only when bleeding was so severe that the soldier would die without immediate intervention. They were also one of the most dangerous techniques in the field kit, because improper use could cause more harm than the original wound. Soldiers learned to make tourniquets from belts, bootlaces, strips of cloth, or anything else that could be wrapped tightly around a limb and twisted to increase pressure. The process required a rigid object like a stick, rifle cleaning rod, or even a pencil to serve as a windlass. The cloth or strap was tied around the wounded limb above the injury, Then the rigid object was inserted into the knot and twisted until bleeding stopped. This had to be tight enough to completely cut off blood flow, which meant the pressure was extremely painful even for unconscious soldiers. Once applied, a tourniquet started a countdown. Cut off from blood supply, the tissue below the tourniquet would begin to die within hours. This meant the limb would probably require amputation, but it also meant the soldier would live. Military doctrine was clear: better to lose an arm or leg than to bleed to death in a foxhole waiting for help that might not arrive. For chest wounds, especially the dreaded sucking chest wound where air entered the lung cavity, soldiers used whatever waterproof material they could find to seal the hole. The cellophane wrapper from a cigarette pack was ideal because it was thin, flexible, and completely airtight. Some soldiers carried small pieces of rubber or oiled cloth specifically for this purpose. The technique was to cover the wound completely with the waterproof material and tape or tie it down on 3 sides, leaving one side slightly loose. This created a one-way valve that allowed trapped air to escape from the chest cavity while preventing more air from entering. Without this treatment, air would continue entering the chest with each breath, eventually collapsing the lung and potentially causing fatal pressure on the heart. Shock was often more dangerous than the wound that caused it, and treating shock was largely about supporting the body's basic functions while it dealt with trauma. Soldiers were taught to keep wounded men warm using blankets, coats, or any available covering. Body heat was critical for maintaining blood pressure and preventing the cascading organ failure that defined traumatic shock. Elevating the legs helped return blood to the heart and brain, improving circulation to vital organs. In combat conditions, this might mean propping feet up on a backpack, helmet, or pile of equipment. The elevation didn't need to be dramatic, just enough to help gravity assist blood flow back to the core. Keeping wounded soldiers conscious was another critical element of shock treatment. Soldiers were trained to talk continuously to wounded men, asking questions, giving updates on the tactical situation, or just maintaining conversation. Consciousness was often the difference between recovery and death, as unconscious soldiers were more likely to slip into fatal shock or suffer complications from their wounds. The goal of all these techniques was never to cure, only to buy time. Every minute a wounded soldier remained stable was another minute for help to arrive, for evacuation to be arranged, or for the tactical situation to change enough to allow movement to better medical care. Real battlefield medicine happened in conditions that would challenge even experienced doctors. Soldiers treated wounds in muddy foxholes where the only light came from muzzle flashes. They worked in bombed-out buildings with debris falling around them. They administered first aid in dense forests where enemy snipers waited for any sign of movement. This wasn't the sterile environment of a hospital operating room. This was survival medicine practiced under the worst possible circumstances. Sanitation, one of the basic principles of medical care, was often impossible to maintain. Soldiers treated wounds with hands covered in mud, gunpowder residue, and dirt from crawling across battlefields. There was rarely time to find clean water for washing, and stopping to boil water or sterilize equipment could mean the difference between life and death. They did the best they could with what they had, knowing that infection was a risk they'd have to deal with later if they survived the immediate crisis. The psychological challenge of self-treatment under fire cannot be overstated. Natural human instincts worked against effective medical care. When wounded, the body releases adrenaline and other stress hormones that can cause tunnel vision, shaking hands, and impaired judgment. Soldiers had to overcome these physiological responses while potentially still taking enemy fire, making life-or-death medical decisions about their own bodies. Many wounds that would be considered minor injuries by today's standards were potentially fatal in World War II combat conditions. A simple laceration that nicked a blood vessel could cause a soldier to bleed to death if proper pressure wasn't applied quickly. A broken bone that punctured skin created an open wound vulnerable to infection that could kill weeks later. Even minor cuts and scrapes could become infected and lead to gangrene or blood poisoning without proper treatment and antibiotic therapy. The techniques soldiers used, basic as they were, saved thousands of lives that would have been lost in earlier conflicts. World War II had a significantly lower death rate among wounded soldiers compared to World War I, largely due to improved first aid training and better individual medical supplies. Soldiers who might have died from blood loss or shock in previous wars lived long enough to reach aid stations and field hospitals where more advanced treatment was available. Improvisation was a constant necessity. When first aid supplies ran out, soldiers learned to use torn undershirts as bandages, bootlaces as tourniquets, and rifle cleaning patches as gauze. Strips of parachute silk made excellent bandage material. Empty ammunition boxes could be used as splints for broken bones. Soldiers developed an almost intuitive ability to repurpose ordinary equipment for medical use. The buddy system became crucial for treating wounds that soldiers couldn't reach or treat themselves. Back wounds, head injuries, and wounds to both arms required assistance from fellow soldiers. In infantry squads, everyone learned basic first aid because anyone could be the one who needed to stop a friend from bleeding to death. They practiced these techniques during quiet moments, rehearsing scenarios where they might need to treat each other under fire. Working as medical teams, soldiers learned to divide responsibilities efficiently. One soldier would apply direct pressure to a wound while another prepared bandaging materials or called for a medic. A third might provide covering fire to protect the wounded man and his helpers. This teamwork was often the difference between successful treatment and tragic loss, especially during active combat, when time and safety were both in short supply. The morphine syrette created its own set of challenges and protocols. After using morphine, the empty syrette had to be pinned to the wounded soldier's uniform in a visible location, usually on the forehead, collar, or chest. This told medics and doctors exactly when the drug had been administered and prevented dangerous overdoses. Morphine's effects lasted several hours, and giving additional doses too soon could stop the patient's breathing entirely. Soldiers learned to read the metal tags attached to use syrettes, which were stamped with timing information. They also learned to observe wounded men for signs of morphine overdose, slow, shallow breathing, blue lips or fingernails, and extreme drowsiness beyond what the wound would normally cause. If these symptoms appeared, the priority became keeping the wounded soldier conscious and breathing rather than treating the original injury. Communication with eventual medical help was another critical skill. When medics or stretcher bearers finally arrived, wounded soldiers needed to quickly and accurately describe what treatment had been given, how much morphine, when it was administered, what type of bandaging was used, and how long pressure had been applied to wounds. This information allowed medical personnel to continue treatment effectively without duplicating or contradicting field care. What's remarkable about this system is how effective it was despite its simplicity. Soldiers with perhaps 20 hours of first aid training and minimal equipment managed to save lives that would have been lost in any previous war. They proved that when professional medical help isn't available, basic knowledge, steady nerves, and the determination to survive can bridge the gap between injury and proper medical care. These weren't doctors or nurses with years of medical education. They were farmers from Iowa, factory workers from Detroit, and shop clerks from small towns across America. They learned to perform life-saving procedures under conditions that would challenge trained medical professionals. In the worst moments of the war's bloodiest battles, they became combat medics out of necessity and kept their brothers in arms alive through nothing more than courage, training, and an unshakable commitment to bringing everyone home.